State University, and it is my pleasure to welcome you here tonight. We would like to thank the co-sponsors of tonight's lecture, the College of Liberal Arts and Sciences, and the Committee on Lectures, funded by student government. A few housekeeping items. There will be an opportunity to ask Mr. Kadelka questions. Please note that there's a microphone set up at the front of the room for you to use. Please do not use flash if you are taking pictures. If you leave before the Q&A is finished, please exit quietly and refrain from talking until you have left the room. A lectures program student worker will be in the foyer to scan your student IDs if you are here for extra credit. Card scanning will not start until the lecture is finished. Finally, I'd like to briefly announce an upcoming event. On Thursday, April 3rd, specialist in public economics, Glenn Hubbard will give his lecture, The Wall and the Bridge, Fear and Opportunity in Disruption's Wake. His talk will be at 5:30 p.m. in the sunroom. All lectures events are free and open to the public. A full schedule is available on the lectures program website. Now please help me welcome the Dean of the College of Liberal Arts and Sciences, Dr. Benjamin Withers.
So good evening, everyone. It's a pleasure to see you here on this night that combines both March winds and April showers. Good April Fool's joke for all of us, I think. So welcome, and thank you for joining us for the Spring 2025 College of Liberal Arts and Sciences Dean's Distinguished Lecture Series. I am Ben Withers, as I've just been introduced, and I'm proud to be Dean of the College. This evening is the 38th lecture in the series, which highlights faculty excellence and achievement in teaching, research, and outreach in the College of Liberal Arts and Sciences. There we go. For each lecture, we ask exceptional members of the LAS faculty to present lectures from their own diverse scholarly areas of expertise. They are faculty members who help solve global challenges, who connect the world with art and culture, and who push the boundaries of educational and intellectual dialogue. In the past, the topics have ranged from explorations of the ways that storytelling can connect communities and policymakers, to the barriers that people face when seeking mental health treatment, to what oxygen-free lakes can teach us. So before I introduce tonight's speaker, I want to acknowledge the ISU Lectures program for their role in helping us sponsor and coordinate this event. I would also like to thank everyone from the LAS team who was involved in making tonight's lecture possible. The valuable partnerships that we've developed here heightens our ability to share the college's contributions with the community, and these contributions are greatly appreciated. At this time, it is my pleasure to introduce Claus Kadelka, Associate Professor in the Department of Mathematics. Claus combines methods from his training in mathematics with medical virology to tackle critical challenges in future pandemic preparedness. With support from the National Science Foundation, Claus has studied gene regulatory networks which fundamentally control how our cells function. In tonight's lecture, Claus will bridge a variety of disciplines from mathematics and statistics to sociology, biology, and public health. Combining rigorous theoretical analysis with advanced computational techniques, Claus uncovers how human behavior and complex social processes intertwine in disease spread. He will help us understand how this interdisciplinary approach to refining infectious disease models can better predict and mitigate future outbreaks. LAS research truly does transform the world by addressing the challenging issues of our time, and Associate Professor Kadelka is no exception. So please join me in welcoming the Spring LAS Dean's Distinguished Lecturer, Associate Professor Claus Kadelka.
Great. Is the microphone on? Yeah. Thank you, Dean Withers, and thank you to the LAS team that prepared all this for allowing me to come here and present my research. I want to take 40 minutes or so to give you a brief overview of how insights from many, many disciplines, mathematics being just one of them, can help us be better prepared for the next pandemic that will strike eventually. It's not a question of will it strike, it's a question of when will it strike and what will it look like. Before I get there, because I know there is a couple students in the audience, or a bunch of students, I want to briefly take a moment to tell you how a mathematician by training like me got to doing this kind of very interdisciplinary research, right? So starting out, graduating high school in Germany, I always wanted to study medicine. My GPA was not a 4.0. I did not get into my dream med school, and so I ended up studying mathematics because I was always good at it. As part of that study, I got to go to Virginia Tech for a 2-semester exchange program, ended up meeting my wife, ended up staying for 12 semesters, doing a PhD. And I realized fairly quickly that just studying mathematics for the purpose of studying mathematics, as I was looking at financial mathematics and its theorems, is kind of useless, because we always assume that the market and the individual is rational, and once you drop that assumption, which is obvious nonsense, then you're looking at decision theory and it all gets messy, right? So that's when I was able to merge my interest in biology medicine with math, and I joined research on gene regulatory networks at Virginia Tech during my PhD. And then I said, once I was done with this and I was looking at postdocs, I want to do something even more applied. I ended up being in Switzerland in one of the leading HIV labs, and I was one of 2 or 3 computational people among like 50 to 80 clinicians, doctors, virologists. And all of a sudden I was the expert in machine learning and statistics, things that I've heard about before, but I by no means felt like I was the expert. So I became the expert in 3 years, more or less, before coming to Iowa State, where I wanted to go back to my gene regulatory network research, which I really liked and really thought is interesting and is something that I can do in the math department. And then the pandemic hit. And all of a sudden, I was looking at some early mathematical models, and I realized this is, quite frankly, a bunch of nonsense, because the people that build these models, they have no clue of the underlying virology, right? And so they're just mathematicians. They're not talking to other people outside of the field. And what we really need to do is we need to take all these different insights into consideration. So that's what started me working in like the beginning of 2020 on infectious disease modeling. So before we begin, I just want to give you a couple definitions, right? All of you have heard of the pandemic. You've all lived through a pandemic. All of you have heard about the term epidemic. The difference between pandemic and epidemic is kind of vague. It's really about the size of the outbreak. A pandemic, pan meaning all people in the world being affected, more or less. Epidemic is more localized. Like you have an epidemic, for instance, right now, a measles epidemic, measles outbreak in Texas, but this is by no means a pandemic yet. A third term that goes along with this is the endemic disease. Those are things like malaria, or much milder, the common cold, right? Which are always constantly present at some low level. And while we're at definitions, let's look at how the World Health Organization defines infectious diseases. They say this is a disorder caused by microorganisms, typically viruses, bacteria, fungi, or parasites, that can be spread either directly or indirectly, or both, by contact from one person to another. So here are a couple examples. We all know some viral diseases, right? COVID, the flu, HIV, which causes AIDS, Ebola, and so on. We know some bacterial diseases. The fungal diseases, they're much less known, much less prevalent, much less severe. And then we have some diseases caused by parasites, like malaria. So what I want to show you here, and I should say, right, none of these graphics are made by me. I just found them on the web. I thought they're really useful. So specifically, Our World in Data is a really great source for nice graphics. What I show you here is that time and again, humanity has faced pandemics. Starting in the Middle Ages, right, all of you have heard of the plague pandemic, where in Europe, over the course of 6 years, more than 50% of all people just died due to this disease. Less known, but even more severe, is when the Spanish came to conquer Latin America. They were greatly aided by disease. They brought smallpox and all sorts of other diseases that were unknown at that point in this part of the world. And it's estimated that that killed up to 90% of the native population. So they hardly had to conquer anything. The disease did it for them. There were other pandemics. Specifically, we had a bunch of flu pandemics over the years. We had the Spanish flu about 100 years ago, which, fun fact, where did it originate? In Kansas. And we had the HIV/AIDS epidemic that started in like the 80s and is still ongoing. People are still dying en masse due to HIV/AIDS. And then obviously you all know that we had the COVID-19 pandemic fairly recently, which close to 30 million people died from. So given this short history lesson, right, everybody here will agree, the question is not if, the question is when the next pandemic will happen. And unfortunately, I cannot give you that answer, and nobody in the world can. We don't know when, we don't know what, we don't know how. We can just make estimated good guesses, essentially. The problem is that these new health threats are constantly emerging. People are living closer and closer and closer, because we are expanding as a human race, to animals. And that means events where a virus or bacterial can adapt from life in an animal to life in humans, and then spread from human to human, they happen more and more frequently. And we don't know which of those events will cause the next outbreak that we cannot contain. So what people do agree on, most experts do agree, is that there is these 25 families of viruses, of millions and billions of viruses that are out there, that all have what they call human outbreak potential. And so the idea is that while we don't know what mutation in what type of virus family will cause this, what we can do is we can use what's called the viral family approach to vaccine design. If we manage to design a vaccine that works well against coronaviruses, another vaccine that works well against, say, the Ebola virus, and so on, right? Then when a new virus out of that family strikes, we are ready. We can just adapt that vaccine, and we have a vaccine ready much faster over the course of like maybe 100 days is the goal, but maybe a couple months, right? Versus years and years of development. And you have seen this in action with the mRNA vaccines that were developed against COVID-19. They were developed in a really short, record time frame, like 10 months or so from start of development, from sequencing of the virus to them being rolled out. And the only reason this was possible is because we had these earlier coronavirus pandemics where people, even though the pandemic or the epidemic was over, they still continued to work on the vaccine. And then we could use all the knowledge that was gained from those coronaviruses to rapidly develop this vaccine by BioNTech and by Moderna. So when you think of infectious diseases, I think this graphic or this statistic is specifically striking. You don't realize the immense burden on our human race that they have. So this is kind of old data. I just put it here because I like it and I couldn't find better or equally well data from like 2025. So this is 2005. And in 2005, where notably we did not have any pandemic going on, we see that 26% of all deaths worldwide were due to infectious or parasitic diseases. So a huge number. The problem, or why there is not more awareness and more research into infectious diseases, is that unfortunately most of the disease burden is in the low-income countries. So we in the US and Europe and all the countries that have a lot of money to do research, we're not that affected. And specifically, if we look at this graphic where we're looking at all the low-income countries and how many years of life are lost either due to premature death or due to some disability that lowers your quality of life, then we see that in the lowest income countries, most years of life lost are actually due to infectious diseases in red. And we see that in the high income countries, it's much more the non-communicable diseases like cancer and heart disease as some examples. For the statisticians or those that like graphs, I put this up here where you see this even more striking, right? You see that, yes, there is some negative correlation between the per capita income in a country and the the burden due to non-communicable diseases like cancer or heart disease, but that correlation is much stronger if you're looking at infectious diseases. So after this general introduction to infectious diseases, I want to talk a little bit about, what is mathematical modeling and how can it be useful to predict and to mitigate the next pandemic. First, before I describe specific models, I want to look at some news headlines that are all from just after the pandemic started, right? So we are looking at spring 2020. And the first one here is from the journal Science, one of the top journals in the world. And it essentially describes how infectious disease models have a huge responsibility because whatever our models say is getting turned into policy. If the model says you have to close all the schools and all the business, well, then that's what happens. So you have to be careful what kind of modeling assumptions you make, making the right modeling assumptions so that you're not getting bad outcomes, inaccurate outcomes. Here's another one that describes how mathematical models basically describe, what level of social distancing is needed, how large a group size we can meet in, and what should we avoid. And there's another one here. This is one of the most highly cited papers that came out of the pandemic research, where they built a mathematical model and then they used it to determine the effect of control strategies to reduce essentially the burden of disease in Wuhan, China. But, and that's a big but, there is also a lot of negative press that came out early on, right? So here is this article by Vox.com where they say, there is a wrong model, and even though we know the model is wrong, we or the White House is constantly using this model to make predictions. Not a good idea. There is another one, another influential model by some of the leading people in Britain, where there are some flaws, but they're not being fixed. They're still being used by the public health decision makers. And most interestingly, or most frankly, John Ioannidis, one of the most highly cited scientists in the entire world, he is particularly frank, and he says forecasting for COVID-19 has failed. Boom, done. It's bad. And he goes there and he says, here is the reasons for the failure. And while I don't have the time or want to go through the entire list of what he says, I want to focus on those specific reasons that my research and my research group is trying to address, right? So we are working on building models that have accurate assumptions. We are working on incorporating, through the collaboration with people from different disciplines, many epidemiological features that are important. And we want to look not at only one dimension, but we want to look at multiple dimensions. So for instance, if you are designing, and that was my first research project with a statistics PhD student here, if you're designing policy recommendations for how much should we socially distance, who should be treated in the hospital first, if there's hospital overcapacity, and who should get those limited tests, then we need to look at all of those things at the same time. We don't only look at one or the other or the third policy domain. So really, my key takeaway from reading this paper and looking at what they claim is we need multidisciplinary science. Before showing you specific infectious disease models, I want to go over a couple quotes and then show you this graphic that I always show the students in my math modeling class in the first day of class, where starting with a British philosopher in the 14th century, William of Ockham, he essentially came up with a problem-solving principle that is nicely summarized in this cartoon here, right? When faced with two equally good hypotheses or models, you should always choose the simpler one. Albert Einstein supposedly summarized this as everything should be made as simple as possible, but not simpler. And John von Neumann, one of the fathers of the modern computer, he said, truth is much too complicated to allow anything but approximations. And that is also kind of like what George Box, a famous statistician, said. All models are wrong, but some are useful, right? We are not trying to get it perfect. We're just trying to make something where we can learn something, where we can deduce policy, or where we can decide whether a certain policy intervention is useful or not. So over to this graphic on the right, what this means is that you can never get to perfect accuracy. What you're trying to do is you're trying to build a model that is, borrowing terminology from economics, Pareto optimal in the sense that it is as simple as possible given a certain level of accuracy. Or phrased differently, right? So this little x here, I think I can point, yeah? This little x here would correspond to a model that is not optimal, because I can either simplify it without losing accuracy, or I can improve the accuracy without making it more complicated. Let's now look at the most classical infectious disease model that's about 100 years old and was formulated by two Scottish scientists, Kermack and McKendrick. And what they do in their model is they say the entire population, let's say everybody in Ames, or everybody in the state of Iowa, everybody in the US, right, is stratified into three compartments: those who are susceptible to the disease, those who are currently infected and infectious, and those who are recovered and assumed to be immune, S, I, and R. And what they then do is they say, let's borrow the law of mass action from chemistry, and let's look at some chemical reaction, so to speak. If a susceptible person and an infected person interact, then that leads with the rate beta, the transmission rate, to two infected people. And if you have an infected person, that person recovers at a certain rate R. The transmission rate here captures everything from like the internal biology of the virus or the pathogen to whether or not we are engaging in social distancing or wearing masks, right? So if you have a more infectious variant emerging, so all of that is captured by beta. So over the course of a pandemic, beta is certainly not constant, but is changing over time. And the recovery rate can capture things like whether there is sufficient resources to treat people, if drugs are required to become, to recover. Do we have enough drugs? If we don't have enough drugs, well then R is lower. The rate is lower at which we recover. And the key term when you study infectious diseases that I am fairly confident a lot of you have heard because you've lived through the pandemic is the term of the basic reproduction number. What this tells us is it tells us the number of people that the initially infected infect over the course of their infection. So if the entire population is susceptible, how many people will I, the first person having the disease, infect? Nobody knows, nobody's practicing social distancing, right? So that is what this measures. And I'm going to show you a little bit of math, not much math, but a little bit of math. So if you want to compute this for this simple model, it's fairly simple. It is beta times S times 1 over R. What is beta times S? That is the rate at which we infect people. What is 1 over R? That is the time that on average I am infectious. So if I multiply the two, then I get that number. And because I know that initially everybody is susceptible, I just get beta divided by R. Transmission rate divided by recovery rate. Very simple. So if we now look at some dynamics, then we see that if my R naught is 2.5 with a recovery rate of 0.2, meaning on average a person is infected for 5 days, and a transmission rate of 0.5, then I see this. I see that initially everybody's susceptible, and then infections take off up to a peak, and then they decrease again. So I have an epidemic peak, and then the disease vanishes. This is describing the typical course of an epidemic. What we see if we lower R naught, then we see that fewer and fewer people become infected. The peak is lower and lower. And if you look at the final number of people that are infected, so looking at the green line over here, right, we see that the lower my basic reproduction number, the lower that final number, which we call the final epidemic size. What I now want to do is I want to describe some shortcomings, and that is essentially the remainder of my talk. Most of it is describing some of the shortcomings and how can we overcome them using new research ideas. So the first shortcoming that I'm working on with a PhD student, third-year PhD student in applied math, up there, Sharir, is that this SIR model just gives us a single epidemic peak. But we all know we had multiple waves of infection, right? There was like the second, the third, the fourth, the Omicron wave, which was the worst of all if you just look at absolute numbers. So how can that be? Well, there is several obvious reasons how that can happen. There is seasonality, which we see with the flu, right? We have very few flu infections in the summer and then very many in the winter. There is the emergence of more transmissible variants. There is waning immunity, that people who have recovered are not lifelong immune, but they eventually become infectious again, and so you can get these waves. But our hypothesis here is that human behavior alone and the way that we make decisions is sufficient to get these multiple waves. So what we mean by that, or how we show this, is we say rather than having a constant transmission rate beta, we have a transmission rate that depends on the level of disease prevalence. At the population level, if you have a higher disease prevalence, then people are more scared of getting infected because there's a higher risk of getting infected. And so at a population level, we're practicing some level of risk mitigation. I call this here contact reduction, but this captures everything from social distancing, mask wearing, yada, yada, yada. So while I don't know, the specific shape of this function, I can assume that it has a general shape like this, where I can move this C value, where I have 50% reduction left and right, and I can move the sensitivity of this function up or down. So what we did is we looked at the classical SIR model, where we get one single peak, and then we looked at what happens if we have this risk mitigation that depends on the disease prevalence. And what we see here in red is we see that we then get one prolonged peak of infection. Not really what we saw during the pandemic, we said, right? And we realized that what we're missing is we're missing the fact that people are not informed about the exact number of cases right now. There is a certain delay in case reporting, in testing after you've become infectious, in decision making. So there's multiple reasons for why we have a delay. And if you include such a delay, in our case here 5 days, but we varied that, right? Then you see that that alone is sufficient to get these multiple waves. What I want to do next is I want to show you several other extensions, some by me and some generally by the field, right, of how we can build better infectious disease models. All of you know that if you're infected with the SARS-CoV-2 virus, right, that causes COVID-19, you're not immediately able to infect other people. There's a certain latency period or incubation period where the virus builds up in the cells of your body, and then eventually you have enough virus particles that if you breathe out, well, I can infect you. So what that means is we need to account for that in the model, and the way we typically do this is we say we have an additional compartment here in between S and I, and we call this the exposed compartment, where people that become infected, they're now moving, there's a typo here, they're moving into the exposed compartment, and then they're leaving the exposed compartment at a certain rate. For instance, for COVID-19, it was roughly 5 days, so this rate would be 1/5, and then you're going into the infectious compartment. We can spin this further and further. There is like an infinite number, so to speak, of these compartmental models that we can build. Here is a model of malaria transmission, a very simple model. We have susceptible humans, infected humans. We have susceptible mosquitoes and infected mosquitoes. And there is this transmission dynamics where the mosquitoes infect the humans, but then the mosquitoes also get infected by humans, if they're sucking infected blood. So what I want to show you here, and this is work a couple of years old from 2021 with one of my former postdocs, Rafael, is I want to show you a very large such compartmental model. In this case, we have 340 such compartments. We have 17 different groups stratified by age, occupation, comorbidity status, and living condition. And we have 20 different disease compartments where I have here the susceptible people who are not willing to get vaccinated. I have the susceptible people willing to get vaccinated. I have those who are already vaccinated. And all of them can become infected, but the rate at which vaccinated people become infected is lower, captured here by this parameter. So many parameters. The model accounts for many different things like vaccination, vaccine hesitancy, the fact that we have some asymptomatic cases and some symptomatic cases. So when you're exposed, it's not clear whether you're becoming asymptomatic or symptomatic. And also different ages, right? Because obviously, if you're studying COVID-19, you have to look at age because there is such a difference in case fatality ratios. So here are the differential equations. I'm not going into detail looking at them. What I want to do instead is I want to tell you why did we build such a large, accurate model, and what did we do with it? What we wanted to do is we wanted to look at the CDC recommendation, the Centers for Disease Control. They said that when the vaccine gets rolled out, every state should basically adapt this sort of rollout, where in the first phase, they used like a euphemism, they called it 1A, 1B, 1C, and 2, so nobody's in phase 4, everybody's in phase 1 or 2, right, but it's the same. Where in the first phase, they said, let's give it to healthcare workers, and let's give it to the elderly that live in nursing homes or so, congested living conditions. Then let's move to the frontline essential workers, then the other essential workers, and the remaining public that has high risk, and also, like some of the elderly that are not in congested living conditions. And then as the last phase, let's give it to the kids, and let's give it to the remaining adult population that has not yet gotten it. What we did is we said, well, let's investigate if this was optimal, right? We have to define what optimal means. To do this, you can say there is a total of 4 to the 17, so roughly 17 billion possible allocation strategies, where I distribute the numbers from 1 to 4 across these different groups. Using math, we can show that a lot of them, most of them, cannot be optimal, and only 17.5 million can be optimal. So what we then did is, thanks to the supercomputers that we have here as free access as LAS faculty, we used a supercomputer and we ran our mathematical model 17.5 million times. And we asked, which one gives us the lowest death? Which one gives us the lowest predicted number of cases? And that's what I show you here. So if you look at which one gives us the lowest number of deaths, you see it's an allocation that is very similar to what the CDC came up with, right? But not the same. We found, I think it's like 0.19% lower than the CDC. So I would say they did a phenomenal job without having, this is a post hoc analysis. They didn't have access to that when they designed the strategy. And so here you see, kind of interesting, all the different 17.5 million strategies, they fall within here, where I look at the death on the x-axis, I look at the cases on the y-axis. And if we are focusing in on this Pareto frontier, then we see that while the CDC strategy was not optimal in minimizing cases or death, we see that it was very close to optimal, and it focused specifically at reducing death, right? And now, while this is an interesting result by itself, what really is one of the key reasons why we use mathematical models is that we are now able to ask counterfactual scenarios. We can ask counterfactual questions like, what if? So what if I had not vaccinated children in phase 4, but I had forced children to be vaccinated in phase 1? We would have gotten, no matter whether you're trying to minimize death or cases, a much worse outcome. What if we had not chosen to vaccinate healthcare workers without comorbidities in phase 1? Maybe they should have been phase 2 or 3. No, our model says it was the right choice to put them into the first phase. So what I want to do now is I want to look at yet another, and that is the key focus area of my research group, shortcoming of classical infectious disease models, and that is the idea that in these models, the entire population is homogeneous and well mixed. Homogeneous meaning I'm equally likely to interact and infect anybody in the population. Now, obviously, that's nonsense, right? I'm currently in Ames. I cannot infect anybody in California, so there's this level of spatial heterogeneity. But even in a small community like Ames, we have other sources of heterogeneity, and that is nicely captured by the social science term homophily. So if I had to describe homophily, I would describe it as people interact more likely with similar other people. I am from Germany, so I am more likely than most of you to have many German friends. There is homophily with respect to ethnicity, race. There is homophily with respect to religion. There is homophily with respect to gender. And basically any attribute you can think of. It's very hard to find an attribute where there is no positive level of homophily, right? But the unfortunate reality is that infectious disease models don't really account for that. We assume everybody's homogeneous. The population is homogeneous. And if you have high levels of homophily, that can lead to big issues, big inaccuracies, bad predictions. So the idea how we measure homophily is that you have different types of people. In this case, I have the blue and the green people, and some of them interact with each other, denoted here by these edges between the people. And what you now do is you ask, well, what is the expected number of interactions among people with the same opinion, characteristic, whatever color represents here, right? And you say, well, that should be 50% because I have 3 and 3. But what we observe is that 6 out of 8 of these edges are among people of the same attribute. So that means we have 50% homophily. If all of them would be among the same people, then we would have complete segregation and we would have 100% homophily. So we have a way to quantify the level of heterogeneity, homophily, in here. And what we now need to do is we need to find a way how we can incorporate this in existing infectious disease models. There are models that are good on many levels, right? But they are just missing this heterogeneous mixing part. So what my group does is we're trying to develop tools that can be essentially, think of like plug-in ready tools where you say, you know, keep everything the same, just add this to your model and you're doing better. And we want to do this for these differential equation models that I've shown you here. And we also want to do this for what's known as agent-based models, or I would like to call it individual-based network models, where you're studying the spread of an epidemic on a network, which is more realistic but computationally a lot more expensive. So what I show you here is I show you what's known as an age-stratified contact matrix, which tells us there is tremendous amount of work that has gone into this, like diary-based surveys in European countries that have then been expanded to other countries. And it's not really feasible to do that for every country, so these are synthetic contact matrices, right? But what it tells us is it tells us on average, if you are, let's say me, I'm 35 to 39, so on average I have this many contacts with people 0 to 4, well I have more, I have many little kids. I have this many contacts with people of every age group, and what we see here is we see high levels of age-associative mixing or homophily with respect to age. We also interestingly see these off-diagonals. This is parent to child and child to parent relationships, and then you have the grandparents with their grandkids. So we need to take this into account. And the way that we typically do this, so how we expand these models, and I'm not the one who invented that, right, how we expand that. I mean, we'll talk about our contribution later on, is that you say, well, I don't have one group of susceptible, I have 16 in this case, such groups, right? 5-year age bands. And what we then do is we say, let's have a specific transmission rate for each age group, and let's take this matrix, Xij, and describe the mixing patterns in here, where if there's lower mixing among two age groups, well, then they're less likely to cause infections among each other. Why does this matter? Well, it matters because it allows us to appropriately account for the age-associative mixing that we see in any population. But the problem is that there is homophily with respect to so many other attributes that are not accounted for in these contact matrices, right? And so we could do two things. We could either go and we could say we had to do huge surveys and huge survey work to get these age-stratified contact matrices. Let's do even larger surveys to figure out, you know, what is the mixing level based on ethnicity and race in addition to age. But that's not really feasible. That would take years and years and tons of money. So what we do instead is we say, let's come up with mathematical ways of solving this problem, right? And what I show you here is I show you the reason why this is important. If you look specifically at ethnic homophily, here is a study, I think 2020 or 2019 by the Washington Post that asked a bunch of people, you know, what is your ethnicity and who are your closest friends? And what you see is that most white people have white friends, most black people have black friends. So indicating very high levels, 80 to 90% of ethnic homophily, if we're looking at friendship alone, right? If you're looking at all physical context, then it is lower, but still like a substantially higher than 0 level. And why this matters is because ethnic homophily affects disease spread. So if we have a new pandemic, we can expect that to very much, again, follow ethnic patterns. And what we've seen during the last pandemic is we've seen that all those who are non-white or Hispanic and not Asian, they've had substantially higher case and hospitalization and death rates than the white and Asian population in the US. So what we did, and this was an undergrad that did research with me that really like led us to this work, is we asked, well, what if we account for ethnicity in the way we roll out a vaccine? And this is not something that's like way out there, right? 32 out of 50 states, they have at least kept some of the early vaccine doses for specific minority groups. So it's something that has been done, not to this level that we propose here, but it has been done by certain states. So the question then is, you know, we know multiple different things based on census data. Based on census data, we know that white and Asian people that we lump together here, they are on average older. Among the oldest subpopulation, 82% are white or Asian. Among the youngest, only 55. Right? Because of that, because they're older, that would mean we should probably prioritize white and Asian people, because older people are much more at risk of dying from a disease like COVID-19 than young people. But we also know that people of color, they are more working the jobs that cannot be socially distanced. They are in these high contact jobs like meatpacking plants or other places where their level of contact is substantially higher, and therefore there's a lot more risk of them getting infected and then spreading the disease among their peers, right? So that means we should prioritize people of color. And this is not the only trade-off when it comes to vaccine design or vaccine allocation design. There's a second immediate trade-off, that is, should we prioritize the more active young population and then prevent, by reducing the outbreak in general, prevent the older people that are really at risk from getting infected, or should we directly vaccinate the people most at risk, who are not really having a lot of contacts? So having multiple of these trade-offs here and having the high level of ethnic homophily gives really rise to a non-trivial problem that, I'm going to skip all of this because I don't have time, that we solved by saying, well, we need to come up with a way how we can take a existing age-stratified contact matrix and how we can expand this by an attribute like ethnicity, where we don't know exactly what are the mixing patterns with respect to age and ethnicity at the same time, but we have a general idea of what the homophily is. So that's what we did here, and we can then compare, the homogeneous mixing matrix with the heterogeneous mixing matrix, and what we see is that if I do homogeneous mixing, which is what most infectious disease modelers do, right, then I get the classical optimal vaccine allocation where you should first vaccinate the oldest people, then the second oldest, the general adult population, and then the kids. But if you're accounting for heterogeneous mixing, then it becomes a lot trickier. If you're using 4 vaccine phases, and we also looked at 5 and 10, as sensitivity analyses, then you see that the first people you should vaccinate is you should vaccinate the oldest people of color, but you shouldn't do the same for the white and Asian population. No, there you should actually vaccinate those who are working high contact jobs. And then you should go and vaccinate the oldest people of color. And what we could show using the model, and again, it's important to say according to the model. I'm not claiming this is the truth. I'm saying according to our model, if we had accounted for, in the optimal way, for ethnicity and the ethnic homophily that's prevalent in the vaccine rollout, then in 2021 alone, we could have prevented 11,000 deaths in the US, right? So lastly, last 2-3 minutes, I want to talk about what we can do if we are not considering these classical SIR models, but if we just say, let's look at an infectious disease model where we consider a network, where we have, and this is work with Audrey McCombs, a statistics PhD student, where we have different types of people. In this case, they have a different color and a different shape. And we can quantify the edges with the same opinion for color and with shape, and that gives us a level of homophily. And we can also have a non-zero correlation among color and shape. And if we do this, then what Audrey and I did is we came up with an algorithm how we can design any network that has specific characteristics. So in this case, this is a small world network, meaning that if I know someone, that someone knows someone else, I'm also more likely to know that someone else. That is something that we generally know about human contacts. So we take the small world network, we assign these attributes, and then we come up with an algorithm that gives us a defined level of homophily. So we are swapping back and forth these different attributes until we get to a defined level of correlation, a defined level of homophily, and now we can study how does this defined level of homophily and correlation affect the disease outbreak. So that's what we did here on my last research slide, where we said, well, let's look at whether or not you have positive homophily among those people who are vaccinated. Roughly 2/3 of the people were vaccinated here. Let's look at social distancing or risk mitigation also as a binary attribute because it's simple. And let's see if we have positive homophily there or none, how this affects it. Let's look at the correlation, and let's look at vaccine effectiveness, right? Many, many different things. I'm just skipping over here because this is the most interesting plot. If I have a highly effective vaccine, like we had with the mRNA vaccines in COVID-19, right? Then I see that the homogeneous mixing assumption here underestimates the outbreak probability by up to 10-fold. compared to what we call the most likely social context, where you have positive homophily with respect to both these attributes and positive correlation, meaning that those who engage in risk mitigation are also more likely to engage in vaccination. So this is a drastic difference, and it kind of helps explain why, initially we were told 50% of the population need to be vaccinated and this will all go away. Then this increased to 70%, then 80%, right? And then, it's likely going to be endemic. So this is like one part of the puzzle that explains how heterogeneous mixing explains this. So to summarize, right, what is needed is really a multidisciplinary approach here to prepare for the next pandemic. We need to use my expertise in math and in epidemiology. We need to work with people in economics, human decision-making, psychology, political science maybe. And we also need to talk to the people in the lab, virologists, biologists, and people who engineer masks and then can tell us how effective masks are, for instance. So what I do towards that end is I have a starting collaboration with political scientist Philip Viskovich to infer accurate levels of homophily. And what we want to do is we want to conduct a nationally representative survey where we ask people what their political party affiliation is. We ask them several questions about how they would behave if there would be a new pandemic. And while they cannot tell us what the behavior of their friends is like, we can use the political party affiliation kind of like as a proxy to infer accurate levels of homophily. So that's the idea there. I work with an economist, Joy Deep, to accurately model human decision-making. And to end, I just want to show you a really fun fact that I learned about today after teaching a class this morning, and one of the students said, hey, have you heard about that? And I said, no. We have to think outside the box to understand what's going on with human behavior. So what he told me, and I'm not a video gamer, but this is talking about World of Warcraft, I think, is he said that in 2005, the developers of World of Warcraft, and apparently every 2 months or so, they come up with a new patch to keep it interesting so something changes. And so what they did is they developed this new person that you have to fight, and this person spreads a disease. I forgot what the disease is called, whatever. And what happened is that because people care a lot about their characters and they don't want their characters to die from disease, this was a simulation of real human behavior and how people would behave during an outbreak, right? Without actually having an outbreak other than in a computer game. And so what people have realized, and this led to a publication in the top infectious disease journal in the world, Lancet Infectious Disease, they have realized that there's really an untapped potential, and now people are trying to design video games to kind of like emulate this and to see how people are making decisions. So I thought this was a fun way to end this. I want to thank all my collaborators, people that have worked with me here as part of my research group and contributed to this, other members of the group, graduate students, undergrads are working with me, ISU collaborators, external collaborators, and the funding agencies, external and internal funding. Thank you.
So once again, let's thank Claus for this lecture. We do have a few minutes here. If there's questions in the audience, anyone would like to ask a question, please come up here to approach the mic. Looks like we got a couple coming.
Well, somebody has to break the ice. In your simulations, you don't seem to have a mechanism where people don't want to get vaccinated. And in fact, with the rollouts, there was this issue where they would assign vaccines to certain areas, and some of them ended up not being used and ended up being thrown away because of the lifespan and the need for refrigeration and so on. So, but it seems like that would be relatively easy to build into this model as well, and I was wondering if that was something that you had been looking at.
Yeah, in fact, I'm not sure if this is, oh yeah, it's on. So what we did is we did account for vaccine hesitancy. So we have these different groups here, right, different age classes. And for each age class, we had rough estimates for what proportion of that group would be willing to get the vaccine. And so we did factor this in here where we threw, if let's say for a certain age group, 70% of people are willing, then 70% of people are starting out here, 30% starting out here, that will never become vaccinated. But absolutely, and again, I mean, really my short answer, had I not been able to give you this answer, would have been, there's always a trade-off between model complexity and model accuracy, right? Obviously, you can always find ways how these models are imperfect and how you could increase the accuracy. But the question is, at what cost?
Nice presentation, Klaus.
Thank you.
So one point which you made was quite significant of the millions of possible strategies. Somehow CDC managed to latch on to a near optimal approach. And that in itself would be a good message to advertise more broadly at the moment. But one particular aspect of that is you said that vaccinating the health workers first also turned out to be a good strategy, and so you did some modeling to show that that was the case. But I was curious about that aspect of the modeling because, okay, if you don't vaccinate the healthcare workers first, then there's more illness, so that degrades the hospital staffing, that degrades the quality of healthcare, saving lives. I mean, how do you build those sorts of features into the model?
Yeah, so what you typically do is you, or what we did, I don't know, I don't want to say that we're typical. We did two things here. So first, we assumed that healthcare workers have higher rates of contacts, right, than you or me being in a room like this. And second, we assume that there is something called hospital overcapacity. So there is statistics that I believe it is, there's 6 hospital beds for every 1,000 people. Don't quote me on that, but I think something like this. And so what we did is we said that if more people than those 6 out of 1,000 are infected at any moment in time, then you're not getting optimal care anymore. Then the level of care goes down at some rate. I mean, you could argue what that rate should be, but.
Hi, Dr. Kadelka. I'm a bioinformatics undergrad at ISU, and I'm also working on modeling for my research. So I'm curious about how you model the serial dependence in your model and...
Sorry, how I model what?
The serial dependence.
The serial dependence.
Like from uninfected to infected to recovery, there's a serial dependence in them. And for the models, how do you generate data to simulate and test your models, given that the real outbreak in human history has huge year gaps between them and the parameters have huge discrepancies in each outbreak? And sorry.
Let me answer these questions and then we can take more questions, right? So I'm answering the second one first because I'm not quite sure whether maybe some clarification for the first one, right? So for this specific model, right, the answer is obviously model to model dependent. For this specific model here, what we did is we had historic data. We did this in, I think, May 2021, so we already had 5 months of the vaccine being rolled out. And what we could do then is we could do what we call a model calibration. I'm not calling it model fitting because there's way too many parameters here that, you could find hundreds of different parameter fits to fit the case data and the death data. Instead, what we said is we mainly rely on literature estimates that come with some confidence interval, and you can vary within the confidence interval. But for some of the key parameters, like the transmission rate, beta, right, that I described earlier, we want to calibrate our model. We want to pick that parameter that best fits cumulative death and cumulative cases that we have seen from the beginning of 2020 until like May 2021. The first question, either you clarify or we can talk maybe later. Because it's a very specific question about the serial interval and...
Yeah, okay, we can talk later if that's okay for you.
Thank you.
Thank you.
Well, my voice sounds weird on the microphone. I have 2 questions.
All right.
I keep hearing people laughing. How do I say this? The thing with the part with the video game, I heard you said that that there was a thing. I didn't hear what you said about like how people reacted about that. I don't know if you said that or not.
So what happened with this video game? And granted, I learned about this today, so I don't know much more than you, right? Is that this person here, that apparently is really hard to beat, is really hard to beat because they made this person infect all the players. And so what happened as these players, these really good players got infected, they then made it, right? They engineered it, the computer game, so that it spreads to other players. And then what happened in the computer game, in this computer simulation, is we basically saw how people would react if there would be a real outbreak without us ever having a real outbreak in 2005. So it was a glimpse in the future of what would happen in 2020 when actually a big pandemic hit. Does that help? Okay.
So I think it is time for us to take a little break. We've got a reception back in the back. Those of you who have continued questions for Klaus can address them at that time. So let's once again thank Klaus for the lecture tonight. I also want to point out that you're able to watch out for future events related to the College of Liberal Arts and Sciences on our website. So that's las.iastate.edu. Please join us in the future. Thank you for being here tonight. Good job.